Welcome to The Explainer. Today we are diving headfirst into a true ophthalmological emergency, endophthalmitis. This isn't just an infection of the eye, it's an infection within the eye, and it's a condition where literally every single hour counts. The clinical protocol we're about to walk through can be the one thing that stands between a patient and permanent vision loss. So here's our game plan. We'll kick things off with a clinical overview. Then we'll walk the critical path from diagnosis to figuring out the pathogen, and then the treatment itself. We'll wrap up by looking at how to prevent this and the risks we're trying to avoid.
All right, first things first. Let's build our foundation. What exactly are we up against when we get a diagnosis of endophthalmitis?
At its absolute core, this is a severe inflammation happening inside the eyeball. We're talking about an infection that has punched through the eye's natural armor and has invaded the inner fluids, the aqueous and the vitreous. This invasion kicks off a massive inflammatory response that can just chew through delicate retinal tissue, which makes getting in there and stopping it immediately absolutely critical. Okay, so the very first question you have to ask is, how did the bug get in? And the answer immediately splits your path in two. Was it postoperative, meaning it got in during surgery? Or is it endogenous, where it's seeded from an infection that was already raging somewhere else in the body? This distinction is everything because it totally changes your list of likely suspects and what you need to do next.
So let's see how that initial question shapes our whole diagnostic strategy. Given how serious this is, the process has to be fast, but also incredibly careful, because there is just no room for error.
The diagnostic protocol is a flat-out race against time. It all starts with the most important step, getting a sample directly from the vitreous humor. This precious sample, which is often less than a single milliliter, is then handled under the strictest sterile conditions, put onto culture media, and a tiny bit is smeared on a slide for a first look under the microscope. That can give you your first make or break clue.
And yeah, this quote just nails it, doesn't it? Working with a sample this small and this critical feels like you're performing microsurgery right there in the lab. The volume is tiny, the chance of contamination is huge, and a person's vision is hanging in the balance. It really is a test of pure precision.
This brings up a really key point. Choosing your culture media isn't a one-size-fits-all deal. It's a calculated decision. Based on whether you think it's postoperative or endogenous, you pick specific media to create the perfect growing conditions for the bugs you expect to find. You know, some bacteria are notoriously picky eaters. You have to serve them exactly what they like, or they just won't grow. This is where you have to think like a detective. If you suspect an endogenous case, the eye is just the victim. It's not the source of the crime. The real culprit is lurking in the bloodstream. So grabbing blood cultures before you start antibiotics is a must. It's the only way to unmask the primary bad guy and treat the entire system, not just the eye. Okay, so we've got our diagnostic plan in motion. Now it's time to zero in on identifying the specific organisms causing all this trouble. After all, you have to know your enemy to defeat them.
This table is basically our most wanted list, and it's an incredible guide. Just look at the patterns. Acute post-op cases, you're usually thinking about skin flora like staph and strep. A chronic case that shows up months after cataract surgery, you're suspicious of Propionibacterium acnes. Traumatic injury, now you're worried about environmental bugs like bacillus. And endogenous cases, that opens up a whole world of aggressive bugs, including Staph aureus, and even fungi like Candida.
But just getting a name isn't enough. That's only step one. The absolutely crucial follow-up is antibiotic susceptibility testing. This is the linchpin. This is what lets us switch from a broad, shotgun approach to a precise, data-driven treatment. It lets us pick the perfect weapon for that specific bug. Which brings us right to the intervention. Let's look at the specific therapies we deploy to fight back against this incredibly aggressive infection. So imagine a patient comes in with a traumatic eye injury. You absolutely cannot afford to wait a couple of days for culture results. Their vision is on the line right now. The protocol is clear. Right after you take that vitreous sample, you go in with empirical treatment. As you can see, a standard intravitreal combo is vancomycin for your gram-positives and ceftazidime for your gram-negatives. It's a powerful 1-2 punch delivered right to the scene of the crime. Then the lab report comes in, and now you know exactly who you're fighting. So you pivot. You go from that broad coverage to a targeted attack. For a gram-negative bug, you might hit it from two sides with both IV and intravitreal ceftazidime. For gram-positives, you stick with that direct injection of vancomycin. And it's so important to remember that IV vanc just doesn't get into the vitreous very well. And if it's a fungus like Candida, you switch gears completely to a systemic antifungal like fluconazole. And speaking of fungi, when Candida is the culprit, you better settle in for a marathon, not a sprint. Fungi are incredibly tough to get rid of, especially in an immunologically privileged place like the eye. This means you're looking at a long course of antifungal therapy, often for a minimum of 6 weeks, sometimes even longer, all based on how the patient is responding. So the big takeaway on timing is the commitment. This is not a 7-day course of antibiotics and you're done. Successfully managing endophthalmitis means a long, sustained therapeutic effort. We're typically talking about a treatment course that lasts anywhere from 4 to 12 weeks. Okay, we've covered how to react to the infection. Now let's shift gears and talk about being proactive. How do we stop this from happening, and what are our responsibilities when it does? You know the saying, an ounce of prevention is worth a pound of cure, and that's never been more true than it is here. The strategy has many layers. It's got your standard surgical prophylaxis, but it also hammers home the fundamentals that are just non-negotiable, like meticulous hand hygiene. And check out this fascinating little pearl about sonication. You literally use sound waves to shake microbes loose from biofilms on removed implants. It can dramatically improve your chances of getting a positive culture. And this point about reporting, this is a big deal. It's a fundamental responsibility. It is mandatory to report every single identified isolate along with its full susceptibility panel. This data isn't just for one patient's chart. It's vital for tracking resistance patterns and for fine-tuning these exact protocols to protect patients in the future. And finally, we have to talk about the potential bad outcomes. Even if you win the war against the microbe, the initial inflammatory damage can leave lasting scars. Even if you completely wipe out the microbe, the battle might not be over. The sheer force of the inflammatory response, that friendly fire from the body's own immune system, can cause serious collateral damage. This can show up as retinal detachment, vitreous hemorrhage, or chronic pressure changes that lead to glaucoma and cataracts. Often, managing the infection is just the first step in a very long road of managing its consequences.
So we'll end on this question because it reinforces the single most critical urgent action in this entire protocol. The answer here isn't just a lab test. It's the absolute cornerstone of everything that follows. It's C, the vitreous humor puncture. Identification, targeted therapy, patient outcomes, it all hinges on getting that sample and getting it fast. So I'll leave you with this. In the race to save sight from this devastating infection, the journey doesn't start with an antibiotic. It starts with a needle.